I think we're going to go ahead and start. We're going to have some people coming in from classes and other meetings because, you know, when Zooms go back to back, we tend to have some of that. But we want to go ahead and get started so that we have the full time here today. I want to welcome everyone and thank you very much for joining us. This is our first session of our New Frontiers webinar series. I'm excited to have you here. My name is Debra Haire-Joshu, and I'm a professor of public health here at Washington University. And I direct the NIH-funded Washington University Center for Translation Diabetes Research, which is the co-sponsor of this webinar series with the E3 Nutrition Lab at the Brown School, which is led by Dr. Laura Iannotti, who's also on this webinar somewhere. I know I saw, oh, there she is. Okay, there she is. So we're doing this together. As you all know, we're going to be starting a School of Public Health real soon. And part of this is to hear from the really great minds out there around a variety of topics related to diabetes, to nutrition, to malnutrition. And we want to look at global information that we can use and translate domestically and otherwise. So it's really an opportunity to do that and hear from the latest and greatest, let's say. So today we're thrilled to have speak Dr. Mohammed Ali, who will be presenting on the evolution of diabetes epidemiology, prevention and care, and the role of global research. He is, he's got quite a, you want me to go small, huh? Well, okay. Besides the fact that I realized that Mo, I think, knows everybody at WashU. I had not realized before. But I'm going to give you just briefly a little bit about Mo and why everybody was so thrilled when he was able to donate this time today to us. He is the product of 4 different continents in his life. He's got his medical degree from Cape Town. He studied at the University of Oxford and getting his master's in cardiovascular medicine and a degree in global public health. And he also completed in his spare time his MBA and his Family Medicine Board certification at Emory. Since 2008, he's built a really outstanding portfolio that's focused on cardiometabolic health with diabetes and obesity and other related conditions, and healthcare and preventive services, and translation and implementation science, which we all know is our love here. He has served as a scientific consultant and advisor for the CDC's Division of Diabetes Translation since 2010. And he's also worked on reports for the World Health Organization, World Bank, and the National Academy of Medicine. He is the William H. Fogg Professor of Global Health, Epidemiology, and Family and Preventive Medicine at Emory, and he serves as the Vice Chair of Research in the Department of Family and Preventive Medicine, co-directs the Emory Global Diabetes Research Center, and co-leads the design and evaluation for Equity Core of the Center for Diabetes Translation Research at Georgia. I don't know what he does in his spare time. But we are very glad that we can get him for this hour to have him present on some of his work. And please put your comments and questions in the chat. And we'll have time at the end that we can pick his brain for whatever he knows and is willing to share with us from his talk today. So Mo, I'm going to turn it over to you.
Thanks so much, Debra. Very kind introduction. And thank you also for the invitation to be here. And thank you to many of you who are sharing your hour with me. So let's see if we can get the slides up and running. So as Debra mentioned, I'm going to speak on the evolving sort of epidemiology, prevention, and treatment of diabetes. And I'm gonna make a case, I think, that global research has a major role, has had and will have probably an outsized role as we go forward. Just to mention that these are my disclosures. None of them has any bearing on what I'm going to say today. So that's good. And I also want to just say, in terms of a full disclosure, a lot of the data I'm going to share are really not just my work alone, but actually the product of many of the people who make up our Global Diabetes Research Center at Emory. We're delighted that they are with us. We are excited about continued expansion. And so credit goes to many of the people you see on the screen here. So what I'd like to try and do in sort of a 40-minute time period, where hopefully I can leave enough time for questions, is to talk to you a little bit about the idea of sort of the promise of population health as it relates to diabetes, and specifically thinking about the idea of how we have approached diabetes, both prevention and control so far, and how we've used epidemiology to really understand what we should do. Second, to talk to you a little bit about the successes to date and what has been good. But then I want to pitch to you that we are unfortunately going through a tough reality, which is that diabetes continues to grow and that we are having what I would call stagflation in the control and management and prevention of diabetes, such that we are experiencing increasing global burdens of diabetes. I'm going to pitch a couple of provocative ideas of what's holding us back from doing better. And I'm going to pitch two completely separate ideas. One, that we are not implementing what we know should be done optimally, or that there are just too big contextual differences for us to do that. Or second, are we just doing it wrong? Do we have the wrong interventions entirely, or that we're targeting them at the wrong people? And lastly, I'm going to leave you with the idea that I think there are a bunch of opportunities where there are 4 known unknowns that we can address that I think will advance our field forward. So let's start with the promise of population health. And this is what has worked well for diabetes in the last couple of decades. So first, just as a simple primer for those who might not know diabetes, it's a chronic metabolic disorder, which has lots of impacts on the eyes, the kidneys, the heart, the brain, and your limbs quite often. And so as we think about the world of diabetes, everybody, including those on this call right now or on this webinar, fits somewhere along the spectrum here. And hopefully most of you aren't to the right of the screen. The idea is that in any population, you have a distribution of people that's somewhere between, in fact, it's probably 6 to 15% have diabetes. A good 20 to 30% have what we call prediabetes. In other words, their glucose levels aren't quite at the level of what we would consider to be diabetes, but they have a very high risk, probably a 5 to 12 times higher risk annually of converting to becoming, quote unquote, a person with diabetes. And then there's probably about 2/3 of our populations in general, almost in every country of the world, that have normal glucose levels. What we found over the last 4 decades of research are the following: that if we do a bunch of things once somebody has diabetes, like we check their feet, check their eyes on a regular basis, we get their risk factors under control, in other words, their glucose, their blood pressure, cholesterol, help them avoid smoking, and optimize their health status, we can actually lower their risk of complications and mortality. What we also learned, probably at the turn of the century, was the idea that lifestyle changes in people with prediabetes, in particular healthier diets, regular physical activity, could help slow down the progression from having prediabetes to developing glucose levels that are in the diabetes range, if you will. Much of this data really was driven by a lot of observational studies. I'll give you one big example, the Nurses' Health Study from the Northeast, from our friends at Harvard. And in 4 decades of research where they followed this cohort of nurses, in fact, multiple cohorts of nurses in the Massachusetts area, they basically showed the idea that a lot of protective factors, in other words, maintaining a healthy body weight, having a good set of polyunsaturated fatty acids, whole grains, nuts, etc., was protective for things like diabetes, whereas having excessive body fat, potentially too many trans fatty acids, too much meat in one's diet, very Western sedentary pattern of living was making you higher risk for diabetes. And to be fair, the data were good and it made sense to a lot of us. So we built the model of diabetes using cohorts, largely in high-income countries, in particular, the Hoorn cohort in the Netherlands. And we built a model of diabetes that followed this idea that you see on your screen right now. So the idea being that in the years prior to getting diabetes, there was this idea that insulin resistance went up in the body. At some point, that overwhelmed the level of the amount that your beta cells could secrete insulin. And so at some point, that insulin secretion that dropped meant that the body was without insulin. And one developed diabetes, and it got worse and worse and worse with the decades that you had diabetes. And if you then supplant that pathophysiological mechanism graph onto the idea of where one fits in the world of risk, you can see that sort of obesity was considered a big driver of insulin resistance, leading one into this area of what we call impaired glucose tolerance. In other words, a 2-hour glucose level after you've given somebody a load of glucose meant they couldn't handle it. And you'll see the darker orange line went up quickly because those people on a more insulin-resistant basis sort of converted to having diabetes earlier, if you will, and went on to uncontrolled hyperglycemia. Similarly, you'll see the lighter yellow line is sort of fasting glucose. And so we've, over the years, used those two to really understand who has prediabetes, diabetes, and the potential for devastating complications. What also happened at that time is we used both bits of information. All these data from the observational studies and the Nurses' Health Study and the Horn Study and all these others to say to ourselves, okay, what if we go ahead and actually intervene on those lifestyle factors? What if we get people to be more physically active, get them to eat healthier? And so came along the 2 or 3 largest trials in the world, where we took people both in Finland, we took people in the United States, and the data I'm about to show you are those from the United States, the Diabetes Prevention Program, $180 million trial that the NIH supported. And you'll see here, if you look at the gray bars, those are the people that just got basic lifestyle advice and said, go forth and prosper. And you can see that their rate of developing diabetes, the cumulative incidence of diabetes, was high. And they were ticking along at probably about 11% per year of them getting diabetes. Notably, people who received metformin, which is the middle line, it's sort of the pinkish looking line that you see in the middle, had a lower risk of developing diabetes. And those who were given a much more intensive lifestyle change program, where they were counseled, they were helped in how to think about what to order when they go to a restaurant, how to pick your diet, how to pick how active you are, and to almost certainly try to get 150 minutes of physical activity a week, etc. They had the lowest risk. And the risk was literally a 58% relative risk reduction in the incidence of diabetes. I will mention, just for clarity though, the group that was selected here were all at least overweight, and the vast majority had obesity. And in addition, for these trials, they picked people who had impaired glucose tolerance, and for quite a lot of them, they had combined impaired glucose tolerance and impaired fasting glucose, which is really the highest risk group that converts to having diabetes at extremely high rates. What was very gratifying about these data, though, is that when you stratified by race ethnicity, and you'll see obviously that in the trial, a lot more people were Caucasian when recruited and completed the trial, and a very small portion were American Indian or Asian. You'll see, though, that at least with that group that all had the same phenotype, the effect was largely the same. The blue is the group that had got the intervention and has the lowest incidence of diabetes. And you'll notice that the gray is the placebo group who got nothing, and they converted to high rates of diabetes. And so essentially, in those years, this mantra was very easy to get behind. And it's actually a rhyme I used to give in talks all the time about 12 to 15 years ago, is the best 6 doctors anywhere, and no one can deny it, are sunshine, water, rest and air, exercise and diet. These 6 will gladly you attend, if only you are willing, your mind they'll ease, your will they'll mend, and charge you not a shilling. So an extremely cheap and effective way to lower diabetes risk. What about diabetes management? In those days, we had tons of observational data. In the last few decades, we've accrued randomized trial data from the DCCT and UKPDS trials in type 1 and type 2 diabetes patients, respectively. We had the array of what I called the target trials, ACCORD, ADVANCE, and VADT, which said, if we get glucose to a certain level, in particular A1C, will we get less complications and heart attacks and strokes and death? And then what I would consider sort of the big lifestyle trials, Look Ahead and the Direct trial, which I'll tell you about in a second. where we literally, again, tried to counsel people. And in the direct trial, they actually just replaced all of their medications and their diet with a formula diet, essentially composed of 825 calories per day. And that formula diet, they were looking to see if people could maintain remission of diabetes. In other words, just not have diabetes anymore. We also had meta-analyses of all these trials showing that it wasn't just glucose that one had to lower, but blood pressure, cholesterol, and to have aspirin on board. And we would get massive benefits. And so just to show you some of the data that supported all of this in the early years, here are the data for the direct trial I'll show you. And what they were basically showing was that in the intervention group, what they did was they did a cluster randomized trial of about 46 clinics in Scotland. And they gave the intervention group, which was about 150 to 200 participants, this replacement formula diet and took them off all their medications, their blood pressure medicines, their diabetes medicines, and they gave the control arm just lifestyle advice and kept them on their medications. What you'll see here is that with greater weight loss, there was a higher chance of people going into remission for diabetes. So on average, just over 40% of people in the intervention arm went into remission, compared to about 2% in the control arm. But you see here, the more you lost, the more likely you were to be in remission for diabetes. Free from diabetes, your glucose levels were low, you're on no medications. Amazing data. And then in terms of how things have panned out in terms of the ABCDs of diabetes, right? The A1C, the blood pressure, all of that, we've done really well. These are data that I looked at some years ago, looking at over time, national data here in the States, where you'll see for 1999, 2002, all the way to 2007 to 2010, the proportions of the population that had different A1C levels. And in general, we had improvements in the proportion achieving an A1C under 7 over that decade or 12 years. We had much better blood pressure control in that group. We had real big sizable improvement in LDL control, and unfortunately, no improvement in current smoking. But what it translated into was this large effect on diabetes complications, or what we thought was an effect, if you will, which is that myocardial infarction rates in people with diabetes have gone down remarkably between 1990 and 2010, similar for stroke, similar for lower extremity amputation, a little bit less for end-stage renal disease, and a little bit less for hyperglycemic deaths. But we were seeing really a lot of major changes, a lot of positive changes, and a lot of it was based on all of the data I've shown you so far. And if we thought it was just us that was benefiting, a lot of these other high-income countries were also showing declining mortality rates in people with diabetes, and that was true of Israel, some parts of Canada, Scotland, Taiwan, and the UK, as well as the US. So this is all good. This sounds great and wonderful, and why would I need to talk about anything else or be provocative at all? Well, I want to show you our current reality, is that we might be doing well in complications rates, but are we? And are those data now a little bit dated? So, for example, currently and over time, the prevalence of diabetes has not at all bent, if you will. The curve continues upward and to the right. And as of 2021, the International Diabetes Federation estimated that 1 in 10 adults around the world has diabetes. That brings us to over 500 million, I'll say that again, billion with a B, people with diabetes around the world. And what's concerning is that that leads to not only high expenditures, high mortality related to diabetes, but that's the tip of the iceberg, because there is also an estimated 1 in 5 adults around the world who has prediabetes, and 1 in 6 women where their birth or their pregnancy experience was affected by gestational diabetes. And then hearing all that, it will not surprise you that if you look at the graph that I just showed you on the left, and then you look at the right, we have always surpassed the projections we said we would get to. So, for example, if you look to our projections for 2025, in 2003, we predicted that 333 million people would have diabetes. We overshot that already in probably way back in 2011, actually. Similarly, we upped our target in 2006 and said, no, it'll be 380 million. Again, we overshot that way back in 2013. And as you look at each of these targets for 2030, 2040, 2045, we are largely on pace to surpass every single projection we have made for the future of diabetes burdens in the world. So not good. Another thing to say is that while I showed you improvements in diabetes control in the United States up to 2010, the new data from Liz Selvin and her colleague Michael Fang over at Hopkins that was published just a couple of years ago shows that actually we're plateauing out. All those blood pressure improvements that we saw right here in the top right, they're flattening out. All those cholesterol improvements that we're seeing in the data I presented earlier are now flattening out. Similarly, for all risk factors controlled, things are not going well. And if you then look at complications, as I mentioned, until 2010, which is the yellow line in the middle of your screen, you'll have noticed that downtrend in complications like amputations related to diabetes. But unfortunately, since 2010, things have been going the wrong way. We are seeing more amputations. Yes, they are largely driven by what we would consider minor amputations rather than major limb removal. But amputations are on the rise. People are at least losing digits, if not feet, if not higher and above knee amputations. And this seems to be driven pretty heavily by males more than females. But if you're really interested in drilling down to complications, the Division of Diabetes at CDC has a fantastic national diabetes surveillance website that I highly recommend you go visit. It is interactive. You can play around with a number of social determinants of health, a number of factors that you can stratify by. And Steve Benoit and his team have done just a phenomenal job. So it really will help you understand that it's not just the amputations I'm showing you, but strokes and other heart failure and a number of other complications of diabetes are on the rise. So what's holding us back? And here are two provocative ideas for you. One, we are failing to implement and adapt and optimally implement, if you will, the things we know should work. That's one option. The other option is that maybe we're doing the wrong things. Maybe the intervention that we've got for example, prevention of diabetes might be ill-targeted or not well conceived. So let me build out the case for each right here, right now. First of all, the idea that we're failing to implement optimally. Many of you think about implementation science way more than me, and I'm preaching to the experts, but many of you have seen this slide of the idea that if we've got efficacy studies, we think something works under ideal circumstances, the goal then is to show that it works under real world conditions. And then really, as we think about dissemination implementation, we're thinking about what it is that, what capacity is needed, what opportunities and motivation are needed to implement something really well and to scale it up and sustain it as an impactful intervention for the future. And so I put it to you that for diabetes prevention and control, we aren't getting that at the moment. And here are a couple of examples for you. So in the realm of diabetes prevention, here in the United States, we looked at these data a couple of years ago, and I'll start with the idea of just looking at those who had what we call diagnosed prediabetes. In other words, they were aware that they are at high risk of developing diabetes. And here are the data for you that we published a few years ago. Out of 96 million Americans who have prediabetes level glucose, about 15 million of them know that they do. So it's a smallish portion that we're looking at initially. But you'll notice that a number of them get some glucose testing. About 2/3 of them get any advice or referral to do something. But the implementation from clinicians and others becomes smaller and smaller as you go from sort of just giving basic physical activity or dietary advice to actually referring somebody to what we call a weight loss program, WLP, or a formal diabetes prevention program that exists in our infrastructure here in the United States. So you'll see the huge drop-off in actually referring people to programs, and then a fair implementation gap in what advice clinicians are giving people. And you wouldn't be surprised to know that This is the diagnosed group, so they're the most aware. They're probably actually even a little bit more motivated by this. The group that doesn't know, who just has a high-risk ADA score, and they have probably prediabetes level glucose levels, you'll see even bigger drop-offs in receiving any advice and any referrals to programs. What about control? And we can look at this and say, okay, in addition to people with prediabetes, people with diabetes also need the same advice. As I mentioned, the Look Ahead trial showed some benefits. So you'll see here in these data from David Flood from 55 low and middle income country data that he accumulated using WHO data from all of these countries. And you'll notice here a general low prevalence of anybody receiving dietary, exercise, or weight loss counseling amongst those with diabetes. It was less than half in all cases, and certainly a little bit more so in certain regions of the world, in particular sub-Saharan Africa and East and South Asia. You'll notice that for those who require medication, while a fair number of them are getting their glucose medications, and again, big disparities between countries and country regions, you'll see just a very tiny amount of people actually getting cholesterol-lowering medications, which literally everybody with diabetes over 40 years of age should be getting. And so you can see that the gaps are there in terms of implementing what we think should be done, whether it's medication or whether it's lifestyle advice. A similar example, we recently published some data from India showing here, if you look first just at the furthest left on your screen, you'll notice that of those with diabetes, and it was about almost 7% of the population that have diabetes, there wasn't a humongous drop in those that know they have diabetes. The bigger drops were actually in treatment, which is this light blue, and the even lighter blue is those that are achieving control. And you can see the disparities between urban and rural for this too. So again, implementation gaps. Now, the implementation gaps might not be, quote unquote, the fault of the delivery person, the interventionist, if you will. It might also be supply side issues, right? There are unfortunately, to date in the world, unconscionable access barriers for people with diabetes. I'll give you the case of insulin, for example, where if you look at any single one of these down here, from insulin being too expensive to not available at all, to having less than an adequate supply or a poor quality of insulin, you'll notice that when you go from high-income country, which is fairly low, the proportion of people not getting it, to low and middle-income countries, the trend is always upward. In other words, you'll see these 70 and 80% of people in low-income countries are not getting life-saving insulin that is needed for their health and wellness. And what's quite distressing is that if you look at life expectancy in a number of places around the world, even past the turn of the century, life expectancy in people who use insulin is even lower than it was back in Boston in 1939, which is a true shame and a real global disparity that we need to work on. That is not the case, as you can see here, for higher income places like Australia, where life expectancy is near normal for people who need insulin. It's almost 70 years of age. So that's my case for maybe we're implementing poorly. My second case is the idea that maybe we have the wrong intervention, or we're applying the intervention to the wrong people. And this is going to take a little bit of following, so bear with me. I remember conversations very clearly back in 2010 and 2011 with colleagues at CDC, where we were sitting down and digesting a lot of the data from the DPP, from the original trial, and trying to decide which groups with prediabetes should get this intervention. And this should tell you something, was that David Williamson, who was a colleague at CDC at the time, very thoughtful guy. He put this down. He knew right from then that there is this heterogeneity in diabetes phenotypes, in prediabetes phenotypes. And so should we be looking for high efficiency, high equity, or a little bit of both in whom we target? And the way he thought about it was, if you think about every single risk group, and you think about what proportion of the US population that makes up, and then you think about their annual incidence rate and number of new cases that will accrue, the number needed to treat in each of them will help you determine where you should put your eggs, if you will, and where you should place your bet, if you will, on efficiency, equity, or both. And of course, in general, we're trying to get both, right? We're greedy, we want both efficiency and we want equity. And so using the number needed to treat, which is the incidence in the those where there's no treatment versus those that there is treatment, you really get a sense of, and it's the inverse. So the absolute risk reduction, the inverse of the absolute risk reduction. So David and I sat down and we said, okay, if you give this to the whole population, everybody, whether they have diabetes, prediabetes, everybody, that group will get diabetes at an incidence rate of 1% per year. And that'll accrue this many cases, and certainly that's the most equitable, but we would need to treat 100 people to prevent one case of diabetes. So it's kind of inefficient, if you will. What about just taking some BMI groups, and they give you sort of a mix? There's certainly a higher incidence rate, so lower number needed to treat, but not really optimal. We could take the people that were in the trial, so they develop diabetes at a very high rate, and so the number needed to treat is very low, but they just make up a very small portion of the US population with prediabetes. The other option is we could pick the slightly lower risk group, the group with impaired glucose tolerance, and the numbers don't change a whole lot. But if we then took maybe this group with IFG, who make up a sizable portion of the US population, and we'd get the same sort of number needed to treat, that would be the most equitable and most efficient. And certainly picking people who were normoglycemic was no point to it. So if you look at these data, you can really see the calculus that was going through our mind a decade ago or 2 decades ago. When I say our, I mean the CDC, and others who were thinking about who should get diabetes prevention through lifestyle, through structured lifestyle interventions. The problem, I put it to you, is that we were too basic in the way we were thinking about it. And unfortunately, prediabetes phenotypes respond quite differently to these lifestyle interventions. So in fact, these data are from Satish, who I think is here in the crowd. He did a fantastic job of taking individual level data from these 4 trials, a couple of them in India, one in the UK, and one in Japan. And by combining the individual level data, he could identify who had just isolated IFG, in other words, impaired fasting glucose, who had just isolated impaired glucose tolerance, and who had both. And you'll see here, that way, my bad. You'll see here that these were the groups. There was a nice split between those who had isolated impaired fasting glucose and those who had impaired glucose tolerance, and then both. And you'll see here, after a median of 2.5 years, incredibly, the biggest effect, as you can see, a 0.51 hazards ratio in the group that had both a combined IFG-IGT phenotype. A significant effect, 35% relative risk reduction in diabetes in those that had impaired glucose tolerance, but no effect in those that had just isolated IFG. And the critical aspect about this is that last year, the International Diabetes Federation also released some data showing that the prevalence of impaired glucose tolerance and IGT actually varies. Yes, it's probably about 40% IGT and about 40% IFG and 60% in the world are IGT, but that's still a significant portion of people in the world, almost half, who have this IFG phenotype, in whom it looks like conventional diabetes prevention through lifestyle did not work at all. And you'll notice that it happens to be that IGT seems to be less prevalent in leaner populations, and similarly, IFG is more prevalent in these same Southeast Asian and South Asian leaner populations. This is not to say at all that weight loss is not beneficial. You'll see from these data that weight loss and weight management has benefits for other things other than diabetes prevention, like hypertension, like non-alcoholic fatty liver disease, sleep apnea, osteoarthritis, stress incontinence, you name it. A lot of these data are from Look Ahead, but critically, you'll notice that one has to lose a fair amount of weight for these to manifest. And you can imagine, again, if you implement these in leaner populations, they may not have that much to lose, if it makes sense. And such that we may just be barking up the wrong tree in that everything is about weight loss and lifestyle. The other problem I pose to you is that the sustainability of the lifestyle movement is very challenging. And that's that we have this model in our head of obesity, which is that it's driven by energy intake versus energy expenditure. This idea that the intake is driven a lot by hunger and satiation, i.e. satiety. And then expenditure is all both your resting and your active physical activity. And unfortunately, what we haven't really thought about is homeostasis and pathophysiology, which is to say that as people lose weight, the body itself kicks in as energy expenditure also then goes down because the body says, let me conserve more energy. What happens is that then the body kicks in some ghrelin, which is a pro-appetite cytokine from the stomach. And it suppresses all the adipokines and cytokines that actually suppress appetite. And so basically you get to be more hungry and or pick calorie-dense foods. And not only does energy intake come back, but it actually overshoots to the point that some people even gain more weight. And so that's a concern. And if we thought this is just all theoretical, you can see this in a number of studies, including, for example, Look Ahead, where in their 5,000 participants, all of whom had type 2 diabetes and overweight and obesity, with about 15 to 20% of them using insulin, putting them on this pretty restricted 1,200 to 1,800 calorie diet and 175 minutes of moderate intensity physical activity, did lead to big improvements in weight loss early in the first year or so. But if you notice after that, as time goes on, there's sort of a regression back to where the control arm ends up in terms of weight over 8 to 10 years. Same thing for waist circumference and same thing for glycemia. In fact, all the big trials, all the big dietary approaches, the Atkins diet, the Zone diet, Weight Watchers, etc., you'll see declining adherence to all of these over a 12-month period, with sort of the first 2 to 3 months being the biggest adherence and the biggest effect for all of these interventions. I showed you data from the DIRECT trial, which was all about remission of diabetes. And you'll notice here again, same thing at every phase of their trial, whether it was the total diet replacement, the food reintroduction, or the weight loss maintenance, people were quitting and they were not completing each phase of that. And that just shows you that a lot of the things we're thinking about are not sustainable. So where do we go from here? I want to leave you with some positive ideas, perhaps many positive ideas. And that's that we need more global and inclusive research. Number two, that I think we would benefit from what I call precision trials. Number three, I think we need to advance the science of implementation on the supply side, but equally, I think we need to advance the science of engagement, i.e. the demand side. And so let me tell you about each one very briefly, and then I'll finish up. So with regard to more global research, why do we need more global research? Well, hopefully I've made a reasonable case that distributions of prediabetes vary around the world, distributions of diabetes, frankly, vary around the world. And in fact, if you look at all the projections from the International Diabetes Federation, where they see the largest increases in diabetes in the coming 2 decades are not in Eastern Europe or the United States. They are in Africa, they are in the Middle East and North Africa, and they are in Southeast Asia and South Asia, where you're looking at anywhere from 60 to 120% increases in diabetes. That is also relevant at home, in that these data from Alka Kanaya and Yiling Cheng, using NHANES data many years ago, showed that the prevalence here in the United States by race ethnic groups varies enormously. If you look at non-Hispanic whites, the crude prevalence of diabetes was 13.3%, and when you adjust it for BMI and age, it's about in the 12% range. But if you look at people who are of Hispanic origin, you're looking at a diabetes prevalence of 17%, and when adjusted for age and BMI, it's 20%. And then look at all Asian groups, it's about 16% when not adjusted, but when adjusted for their lighter weight and younger age, people, when it's standardized, you're looking at 27% in Asian groups. And then you could ask yourself, well, are all Asians the same? Are all Hispanic people the same? And the answer is, of course, no. When you look within each of those subgroups of race ethnicity here in the United States, you just see much higher prevalence amongst people who are Mexican American compared to people whose origins come from South America or Central America. Similarly, you'll see big differences in East Asian versus South Asian, and hopefully some of this, I'll make the point, comes from the phenotype and comes from whether we believe that phenotype is what we would consider an impaired glucose tolerance, insulin-resistant high weight phenotype, which is probably the white and African American and Hispanic groups that you see here, where risk really shoots up between a 22 to 25 body mass index, unlike what we consider as happening probably in South Asians, where as low as BMI of 19.6, diabetes prevalence really starts to shoot up in this population. I wouldn't be complete if I didn't show you these data from Sweden, showing you the idea that it's even more complicated than just BMI and race. This group did a wonderful job of figuring out what phenotypic clusters there are of diabetes in Sweden. And they showed this very interesting data point, which is that, this group here, where they have severe autoimmune diabetes, they are very much like what we consider to be type 1 diabetes. But the rest, people who have type 2, are actually a big and varied group. Some of them just have mild, quote unquote, age-related diabetes. Some have obesity-related diabetes, and others are even more insulin resistant. But a big group of them actually has what we call insulin deficient diabetes. In other words, it's not that their bodies can't manage with the insulin they have. They're not insulin resistant. They just didn't produce enough insulin to begin with. And again, bringing this back to the United States and thinking about how this pans out in our own data, in the NHANES data, I'll show you this slide, which actually shows you the distribution for our race ethnic groups here in the United States, the distributions of people who have diabetes on account of quote unquote older age, which is the mild age-related diabetes. And so you'll notice it's much more prevalent in white and Chinese populations, but far less common in South Asian, Latino, and Black populations. Meanwhile, the groups that have severe hyperglycemia and a lot less of the obesity phenotypes tend to be in the South Asians and in all these other minority groups. So hopefully that points to the idea that by more inclusive research, more global cohorts, we can actually learn more about these different phenotypes and complex phenotypes, not just sort of one characteristic that we are dividing people up on. What understanding those phenotypes does is I think it leads us into the second big opportunity, which is precision trials. I suggest that we have a real opportunity to think about precision prevention of diabetes and precision management of diabetes. In other words, when we figure out the phenotype, we link them with the right medication. I'm not just saying this as a hope for the future. This has been done in certain cases. I'm showing you data here from Andres Acosta, who is at the Mayo Clinic, who's done some phenomenal work in obesity management, where they think about obesity not just as one big group. They think about people with obesity having either a hungry gut or a hungry brain, or that those people are increasing their calorie intake because of emotional hunger and emotional eating, or that they're just not burning the calories that they take in. You would also not be surprised to hear, I'm sure, that a number of these people actually fit here in between two different groups or three different groups. And so there is incredible heterogeneity in people with obesity, which ordinarily for years and decades, we've just thought as one big group, if you will. And you'll notice here that each of these, there's a specific medication compound that works for each of them. And what Acosta's group did, which I thought was fascinating, was that they actually ran a trial. And they showed that those who had phenotype-specific care, they had the medication that worked on their phenotype, actually achieved greater weight loss in all these weight loss categories And if you look here, in terms of sustaining that weight loss over time, there was a bigger effect in those that were phenotyped. So I think the same is probably true for diabetes prevention. It's probably true for diabetes management. We just need to write those trials. We need to run those trials and actually see what the data show us. As I mentioned earlier, I think in parallel, we need to be advancing the science of implementation, and particularly supply side innovations. And as most of you know, behavior change of any sort is hard, both at the patient level because or the participant level or the target level, in that people might have low motivation, a lot of other comorbidities. It might be on the person delivering your intervention, is that there's low accountability, or that they don't have all the evidence they need, or that there's some inertia to act. Or it may be system-related issues like fragmentation and access barriers. As I mentioned, the insulin access barrier is certainly one that we need to act on and we need to work on collectively. I don't think that any one of us is going to solve it alone. Our group, thankfully, at the Global Diabetes Research Center, we've had a phenomenal 15 years of developing trials, implementation trials, pragmatic trials that really focus on how we do better, both in areas of diabetes prevention, where, for example, this study is happening at 8 large employers in India. Some of our other work has been clinic-based and has worked on people both with very poorly controlled diabetes and those with diabetes and depression. And I'll show you some quick data here, is that we've used multi-component interventions like supporting patients through non-physician care coordinators, supporting clinicians through decision support systems, and supporting clinics, giving them dashboards. And we've shown in 2 very different trials that there's tremendous success that can be had there. With low-cost innovations, one can actually improve the needle on diabetes care and improve the supply side tremendously. So these are just data showing you that compared to the control group, who also benefited because a lot of our trials were non-blinded, they were pragmatic trials. In comparison to them, our intervention groups did far better in both A1C control, in blood pressure control, and in cholesterol control. And similarly, in a very hard population, those who have diabetes and depression, we just showed enormous improvements in composite outcomes of achieving control of one's depression and one's diabetes over a 12-month period, which, even though we didn't continue the intervention in the second 12 months, the effect persisted, which tells you something. The idea, though, is that even though we've done well on the supply side on an individual basis, I would put it to you that diabetes is extremely multifactorial, and the issues that are beyond the clinic or the community setting, that go into the natural environment, that go into policy levels, we need a lot more science, population science. And so I think this brings in the area of natural experiments, which really isn't controlled by the investigator. They are things that businesses, communities, local governments are trying all the time to improve the needle, to move the needle on diabetes. And they are policies that really facilitate diabetes care or diabetes prevention, like things like soda taxes, like things like having citywide screenings. And so I'm delighted that CDC and NIDDK do fund some of this work. This is a group called the NextD network that they have funded over the course of the last 15 years. And you can see each of these different studies is covering different parts of the onion ring, but there are plenty of parts of the onion ring that are untouched. And I'm hopeful that more natural experiment research will help us really drive and advance the science of implementation. Lastly, the science of engagement. I think we do really well on the supply side. We don't really know what happens to people who largely spend 98% of their lives outside of a clinical setting or outside of an intervention setting. And so the heterogeneity of people isn't just biological. I would put it to you that it's psychosocial in terms of what innate factors drive them to engage in something, and then what social determinants hold them back or can facilitate their engagement in our different interventions. This is just to say that I think some of that is socially driven, in that people aren't just all motivated by money or by their health. They sometimes are motivated by what other people are doing. And just as one quick example for you, the idea that within households, people can influence each other and risk is communicated within households for diabetes. We looked at this question in the Kaiser data some years ago, looking to see whether, compared to the national average of diabetes incidence, do spouses of people who recently got diagnosed with diabetes develop diabetes at a higher rate? And the answer was wholeheartedly yes. So the group that is the high risk is the spouses of newly diagnosed partners in the gray here. You'll see it's about 50% higher than the national average of diabetes incidence and even the Kaiser-wide diabetes incidence rates. And this was true of different age groups. It was also true, again, of different race ethnicities. So I apologize that this might have felt like drinking through a fire hose. I was trying to intentionally give you a provocative look at diabetes and where we've come in the last 4 decades. My hope is that you take away from this talk that data largely from high-income countries have done a phenomenal job in helping us understand diabetes, coming up with solutions for prevention and management, and trying to get things going. But I argue that we are stalling in our efforts, and perhaps that's because we're not optimally implementing everywhere in the world, and perhaps because we've oversimplified things too much, and we've simplified that we gave it to everybody, and we should really have much more targeted interventions. I think there's lots of work to do, and I hope many of you will join us in global diabetes research. And that's to say that I think we need, first of all, more inclusive and more global research. I think we need more of these precision trials where we match people to different interventions that suit their phenotype. And lastly, as I mentioned, I think we need more of a population focus, both on the supply side and on the demand side. So if you came away worrying that I'm creating a battle between public health and precision health and precision medicine, I would put you to it. It's not either, but it's actually both. And I'm really pitching the idea that as we move into the future is a future of global precision public health. And we need to just figure out how to do that. In the meantime, huge thanks to our team at the Global Diabetes Research Center and to our many funders. Hopefully we have enough time for questions, Debra.
Thank you so much, Mo. That was really good, really outstanding. Okay, I'm going to ask if anybody has any questions. Please enter them into the chat. And while people are doing that, Mo, I want to just ask you, because obviously I'm very interested in the intervention piece and talking about precision intervention in public health. And I'm wondering, because the one piece in this that is driving a lot of what we do now, as you know, is all around social determinants of health, and how that's so, you touched on how that so can even differentiate within groups depending upon the haves, nots, policies, where you live, death by zip code kind of thing. Do you have any thoughts on that when we're talking about precision trials, especially not only in our country, but as we start looking globally, how do we account for that, and how is that accounted for in the data that you presented?
Yeah, that's a tremendous question. It's also a much longer potential answer, but I'll give you the brief version, hopefully, so that we can get more questions. And that's that I think the data probably don't show up those strata in terms of where people just don't have the ability to do it, other than the global data, which are very clear. The disparities are very distinct. I think within the US, we haven't done a great job of looking down at those social determinants, and I think more data are coming. As I mentioned, the National Diabetes Surveillance System has a new ability for you to stratify by different social determinants. And I think they're working on the idea that you might also be able to click on multiple social determinants that people have, so that you really understand who are the highest risk groups. I think some of the population-based work that is happening in the Natural Experiments Network does try to look for what are called high-risk, high-need populations and try to really focus on them. So far, the challenge has been that you can build it, but they don't always come. And so my understanding of that is that we really need to think about the highest need groups as creating some sort of floor, so that everybody at least has the most basic needs for example, food security. And then beyond that is when we can really work on the implementation strategies that get us to improve the quality of what is being eaten, quality, etc., of exercise and those sort of things for diabetes prevention. Hope that answers your question.
Debra, I do think you're muted. Just a quick note.
Oh, sorry, I was asking you to solve everything in a minute and a half, so that was excellent. Okay, Shelly, I'm having trouble reading the, let me see here. Oh, okay, Dominic, I think I see a question from Dominic. As you noted, many African and South Indian populations are insulinopenic early in development of diabetes. Do you have any ideas on broader interventions that can improve glycemia but not increase healthcare costs?
Yeah, that's a tremendous question. So I don't know offhand, but I think we may have the data in the coming 1 or 2 years. I do know of a couple of trials that are ongoing, one in particular in India with newly diagnosed people, and almost like following the GREAT trial where they tried to decide what was the first line medication and they randomize you to that. This particular intervention is randomizing based on phenotype, in particular weight, non-alcoholic fatty liver disease, and a couple of other things. And I suspect that they also will know who's insulinopenic, and they'll also know who's insulin resistant, and again, giving them different medications. So we will likely have some of that data emerging in the coming year or two. But as of yet, other than supplementation and thinking about sort of medication classes like sitagliptin or others that actually stimulate the beta cell without wearing it out, I think those are really the only things we have at our disposal at the moment. Thanks for the good question.
Okay. Laura, do you want to read your question or ask your question, Laura Ayanati? Okay, I'll go ahead and read it. So thank you for the excellent presentation. Globally, we are seeing this enormous increase and public health harms arising from consumption of sugar sweetened beverages. Is this in part behind the explosion in diabetes?
At least in part. I think it's very hard to...
Sorry, Debra, I didn't mean to, I couldn't find my unmute button. Thank you so much, Mo. This is really good. You have food environment on one of your slides, and we're spending a whole lot of time in very low resource settings now thinking about the supply side and the access to these unhealthy foods. So if you could speak to the ultra processed food issue, that would be really helpful. Thank you.
Yeah, certainly. So I mean, many of these surveillance data are not conclusive, but I will say that the latest global burden of disease estimates are very, very similar actually to the IDF estimates, and that they estimate about 500 million people around the world with diabetes. And their assessment was that at least 52% of that was obesity driven. And when you look down and drill down in each of the countries, you look at countries, for example, like Mexico, where soda consumption is probably the highest in the world, or at least, up there, where I think the consumption of soda is something, and this is full sugar soda, is something in the order of 1 to 2 liters per person per day. So you're really talking about sort of, I don't know, 120 odd ounces, up to 120 ounces per day of full sugar sweetened beverages. And it just happens that they also have some of the highest rates in terms of prevalence of diabetes, and diabetes is the #1 cause of mortality in Mexico. So, the patterns seem to line up to what you're saying. I don't think that, again, the surveillance data can tell us why it's happening. They just tell us what is being observed. But great question. I think there was a question from somebody here.
I think from Eduardo Smoes. I think I missed that one because I was having a little trouble with my chat. Is that the one, Mo?
Yes.
Yeah, yes, asking about health IT and a meta-analysis that they had done. I'm not sure I understand the question. I mean, effective health IT was certainly available to the study population, but not all type 2 patients benefit from existing health IT. It's very selective. And asking, I guess, about comments on that. Maybe the use of health IT and how it works, especially, I guess, globally, would have an impact as well.
Yeah, I mean, I think the idea of health IT and thinking about what the promise of sort of AI and all of these different approaches might be is that with good data, assuming you've got good health information for people in your population, I think it helps you drill down and use algorithms and AI tools to really drill down to more distinct phenotypes instead of big broad groups that we used in the past. Instead of just thinking race or age or socioeconomic status group, essentially, these algorithms can allow you to really get at groups of people, for example, who have multiple characteristics at the same time. So you think about, for example, a non-Hispanic, white, poor population versus an African-American, more rich population. And you can actually drill down with health IT. And so I think that's, to me, is the big future, is that we, using our human mind and simple calculation methods won't get there. But I think AI and machine learning, that's the real promise, is that they will help us segment the population much better than we were able to.
So getting at the precision intervention you're talking about, and maybe be able to build in social needs and all of that as well. Great. Well, we are out of time, and I want to thank you very much. That was an outstanding presentation, and we appreciate so much your time, and it definitely gave us food for thought. So thank you so much again, Mo.
Happy to do it.
Thank everybody for coming. This is quite an outstanding turnout. So you're a hit.
Happy to do it. Thank you guys for organizing.
Okay, thanks so much.